Thanks, John. And thanks everybody for coming, because I know the weather outside is incredibly nice. And anybody know the significance of today? Today is National Pie Day. This is a once-in-a-lifetime occurrence because it's 3/14/15, so it's 3.1415. So it's quite an important day. So what we're going to do is we're going to talk a little bit about labor and come with the idea of some of the things that affect the process of labor, as well as some of the things that affect the pain of labor. And I'm not going to stand behind. If you can't hear me in the back, just raise your hand, but I am a kind of a loud talker. So what we're going to do is we're going to review some of the physiology of labor. We're going to take a look at some of the psychological aspects that affect it as we try to understand and take care of our patients on the labor floor. We're going to understand the impact of labor on the mother and the fetus and apply these concepts for the management of the parturium. So if we go through, I was looking at the references and I was looking at my colleagues, and I think most of them had references that are pretty current. I bet you I'm going to use the oldest reference yet. I'm going to be the one that has the oldest in that, and then I'm going to go to the Bible. I'm going to go to Genesis 3:13, where it says, Yahweh asked the woman, "What have you done?" The woman replied, "The serpent tempted me, and I ate." Yahweh said to the woman, "I will multiply your sorrows in childbearing. You shall give birth to your children in suffering." And a lot of people say this was the establishment of, the process of labor and the sensations of labor. And you have to forgive me because I do childbirth class. Every 6 weeks I have to teach childbirth class to the new parents in our hospital. And I got lambasted because I always kept saying pain. And the instructors told me, you can't say the word pain because you're putting in their head that it's pain. I have to say sensations. So you'll notice I'll say the sensations of labor, but I don't think this really established that the pain of labor. I think this established what is I got to say it correctly, ophidiophobia. Anybody care what that word is? Fear of snakes. So anybody who has that, there's the word to take. Ophidiophobia is the fear of snakes, which I have a severe fear of. So what is labor? So if we were to take a look and go to Williams' textbook of obstetrics, this is what you would read. You'd say labor is the physiologic process in which sufficiently frequent strong uterine contractions cause thinning and dilation of the cervix, permitting the passage of the fetus from the uterus through the birth canal. Well, that's really nice, but let's take a look at some of the concept of labor. So on our labor floor, I practice at Penn, and I thought it was very interesting when I heard Dr. D'Angelo talk about these 45-minute C-sections. And I'm like, I don't believe they exist, because I've never seen a 45-minute cesarean section, at least in my institution. I hear the rumor they do exist, but I haven't seen it. So we do, at our place, they do take a look at the Freemans Curve. So you can see here's the classic Freemans Curve, where you see the first stage of labor is broken down into two phases. There's that latent phase, and there's this active phase. And the latent phase where there's minimal cervical dilatation, and then the active phase where you see this very rapid cervical dilatation that's going to occur over 3 hours. What's the problem with this? Well, when Freeman did this, majority of women were, like we heard earlier today, they were 70 kilograms. Majority of them weren't receiving epidurals. So the question is, how applicable is the Freeman curve to the parturient today? Well, that's the question that Frigo raised, and you can see here, that, when we take a look at this, that there is the cervical dilatation, but it isn't this minimal descent and then this rapid cervical dilation. What you have here is it really just pretty much goes up about 1 centimeter an hour, and then here's the descent. And it gives you an idea of what he noticed in these 500 women with epidurals or CSE, that you don't see this latent phase and active phase. It's just this pretty much gradual dilation that occurs with time. But we do have to realize that genomics, and one of the things I think that Dr. Siegel's going to touch in, at least my guess is, when he talks about fever, is the genomics, because that's at least my impression. But genomics plays a factor in terms of the duration of labor. Here's taking a look at the beta-adrenergic receptor, and it turns out that if you have a glycine at the 27 position of the beta-2 adrenergic receptor, you will have a longer labor. And what's interesting about this is that this type of genome is very frequent in the Asian population. And that's why it's been noted that those of Asian descent tend to have longer labors than those that didn't. And the fact is, it's just the fact that it's within the genomics. What do we know about the duration of labor? Well, here's an observational study of 2 years duration. And what they did is they looked at a really good number of parturients, so 400, pretty close to 500 parturients. And what did they do? They divided them up into where they were in the gestation. So they included 36, 37, 38, 39, and 40 weeks gestation. So they didn't use anybody who was post-dates, but we're going to now take a look at these parturients at the various stages of their gestation. And what's interesting, if you take a look at the duration of labor, the duration is clearly related to the gestation of which they are. So that women who are at 36 weeks tend to have a shorter labor and a more rapid cervical dilatation than those later in labor. So as we take a look and going along, the longer you wait, the longer the duration of labor. So something fascinating in that it depends on the gestation. So you can see here that those at 36 weeks have about a 2 centimeter an hour, and then when you go down 1.3 centimeter an hour in the 4. But if you take a look, the duration goes up as the labor progresses. And you can see here that there was a correlation, and the correlation is about 0.1, so not a very strong correlation. So that's really only going to explain about 1% of the difference in the duration of labor. But why do we even care about the duration? Well, we care about this because it has a significant impact on the mother and the fetus. Here's 5,000 parturients who were studied, and you can see here they're going to take a look and they're going to divide the groups into those that were in the 90th percentile for the first stage. There's 251 who are the 90 to 94th percentile. And you can see 143, they're the ones who are the longer. So we're going to take a look and see whose are those that are falling into the normal and those who are having a prolonged first stage. And what do they find? Well, those that have a prolonged first stage are very likely to have a prolonged second stage. Well, that's interesting to know, and that's very helpful, but the most important thing for the mother is it is associated with fever, with the likelihood of the mother developing chorioamnionitis. And it does have significant impact on the newborn. You can see here low APGAR score, and as well as higher chance of the infant being admitted to the nursery. But I think the most important thing is shoulder dystocia. So when we're starting to see these long first stage, everybody remembers that with the long second stage, but when you see these long first stage, we got to be thinking in our head that this might be a really big kid and that this kid is at risk for shoulder dystocia, even in the first stage. So that's important for us that we can align the resources and be prepared to handle any emergencies that happen. And what do we know about the second stage? So here they're going to define the second stage as, nulliparous with 3 hours with epidurals, 2 hours without, multiparous 2 hours with epidurals, 1 without. And you can see here where they look at the incidence. The incidence is not high. Of the nulliparous, only about 10% had a prolonged second stage with epidural, and then 13% without. So we're not seeing that epidural lengthens the second stage. And you can see here vaginal delivery, that with the prolonged second stage, overwhelming majority will have a vaginal delivery, about 80% and up to 90% without. But what's the important thing is take a look at this. Again, a prolonged second stage is associated with infection. Well, is this a confounding variable? Because we already saw that the first stage was associated with fever, and we also know it prolongs the second stage, so it could just be that. And it is associated with a higher chance of the mother developing a 3rd or 4th degree tear, which entails a prolonged repair, and as well as the need for anesthesia services. For the neonate, there's the risk of sepsis, and then there was a greater risk of asphyxia. And I think the most important thing is to take a look at the statement that the epidurals, among the women with epidurals whose second stage was prolonged, and to give you an idea, when we see this, it was a significant number of patients, there were no cases of hypoxic encephalopathy or perinatal death, despite the fact that a prolonged second stage was associated, and that seems to be occurring in the groups that got the non-epidurals. So here you're going to love, because this is now really big on our labor floor, and we're really not very progressive, but boy, this caught hold, and it was published in February, so it's pretty new. And take a look, I guarantee a lot of you have heard of it. It was 198 women, so you already got to come in with the premise. So the premise of this study was that epidural analgesia interferes with the process of labor. So we're already not so happy when we read this study, but take a look at this. 108 women who were randomized to the peanut ball. So what is the peanut ball? The peanut ball is exactly that, a peanut-shaped ball. And what they did is they really did randomize the women, so they either got to lie on their side with nothing, or they put this peanut ball between their legs. And the thought process behind the peanut ball is that it opens up the pelvis and allows for easier descent of the fetus. So that's the premise behind the peanut ball. But you can see here, the most important thing is that it did shorten the duration of labor when you compared the two groups. Now, obviously not blinded, because people knew exactly which they were assigned. But take a look at the risk of cesarean delivery. So their argument is that in women who have epidurals, that putting a peanut ball between their legs decreases the duration of labor, as well as increases their chance of developing having a vaginal delivery. You know, I sit there and I read this and I say, why take fault with it? Very easy to do, very easy therapeutic maneuver, and the answer is if it helps, why not? You know, I'm not going to fight this one, and there is some suggestion, at least this study, and we'll have to see with more data coming out. So we're going to have Mr. Peanut is going to play a larger role on your labor and delivery suite. So what do we know about the pain in the first stage of labor? Well, the pain in the first stage of labor is a component from the mechanoreceptors of the uterus, as well as dilation of the cervix. How do we know the majority of discomfort comes from dilation of the cervix? Well, women have Braxton Hicks contractions before, and the Braxton Hicks contractions just don't hurt as much as when you get the contractions of labor. The difference is Braxton Hicks is false labor because there is no cervical dilatation. But when they start going into this first stage, when they start going to labor, there is the cervical dilatation. And that results in the concept of a visceral pain. What do we mean about the visceral pain? Well, we have to take a look at the spinal cord. And we have to realize that the spinal cord is divided into these various lamina. And you can see all that means is that there's these various divisions within the spinal cord. And the key is that the fibers that innervate the cervix accompany the sympathetic fibers, and they synapse in lamina 5 of the dorsal horn. So the fibers that innervate the cervix are coming up accompanying the sympathetics, and they're synapsing right here into lamina 5 of the dorsal horn. What's the importance behind that? Well, that's actually the same fibers, or the same place within the spinal cord where the fibers, the cutaneous fibers from T10 to L1 synapse. So both are coming to the spinal cord. So the brain says, look at this. I haven't seen firing, from the cervix before, but I have seen firing from the skin, so they're going to refer it to this area. Hence the reason if you ask a woman in the first stage, where does she feel it, she's going to say, somewhere in the T10 to L1 area, and you ask her, where does it hurt? She doesn't say it hurts right here. She says, I feel it right here in my sides and my back. It's a very nondescript, non-specific discomfort that they're experiencing. And the reason is because the brain's referring it. It doesn't know exactly where it's coming from, but it knows it's coming from somewhere in the T10 to L1 area, hence the concept of this referred pain. That's very different than the second stage. The second stage is the baby's descending through the birth canal, and that is a true somatic sensation. The baby's head descending, there's tearing of the fascia and ligaments, and that's carried via the pudendal nerve, a nerve that's very easily blocked by the obstetricians, because when they're ever telling you what is the station of the fetal head, they're saying what is the station of the fetal head to the ischial spines. And as you can see here, the ischial spines, the pudendal nerve, runs very close to the ischial spines. And then this is just a slide to remind you of the various innervations. So you can see here's the cervix synapsing in T5 in the spinal cord of T10 through L1 as compared to the pudendal nerve, which is primary for the second stage discomfort. So what are some of the other factors that affect labor? Because what I've said now is that every single one of parturients who go through the process of labor have the same thing. They all have the cervical dilatation. They have all the tearing. How come some women sit there and say it's not so bad, and others sit there and say that it's one of the worst discomforts they've ever felt in their life? Well, there's other factors that account for the concept of pain. There's anxiety, which I'm going to show you a lot of work on. We're going to take a look at intention and as well as motivation. And this is all the whole basis behind the Lamaze method. The Lamaze method is to remove the anxiety through education, as well as getting women to have less anxiety and more motivated for vaginal delivery. So why should we address the anxiety? Well, here's 46 primiparous patients who are evaluated before, during, and after labor. So we got women evaluated before, during, and after. Anxiety was assessed using some psychological tests. They used the state trait anxiety inventory and the anxiety sensitivity. And I think the key is the more anxious they are, the more pain they think they're going to feel. So that's the key thing. The only thing anxiety correlated with was the discomfort that's going to happen that they imagined beforehand. So they come and think it's going to be the worst thing. Anxiety didn't affect actual discomfort during intrapartum or postpartum, the recall, but it did make them extremely concerned, and they tended to overestimate their pain much more than those that were less anxious. And this I find fascinating. And this has really gained a lot of press in the literature. And they feel that it's this concept of attachment. Attachment is this propensity for an individual to establish these bonds to others for safety and security. So it's really interesting, and it's measured by the adult attachment scale. So you can see here that they did take a look. Oops, sorry. Now you got the joke that's coming out. So they did take a look at the attachment score, and it did correlate. And take a look. The VAS, as well as their ability to not form an attachment, correlates pretty strongly. That correlation coefficient is 0.5. That means 25% of the variability of pain that a woman experiences during labor, the 25% of difference in discomfort that one woman experiences compared to another, can be explained by this concept of attachment, that it has actually a better explanation for the variance in discomfort of pain than demographics, age, or weight. So I think it's fascinating that that is having the greatest impact in determining a woman's experience. And then taking a look here, it has been correlated with consumption of their labor analgesics. Women who are very insecure with their, I'm going to make sure I hit the right one, with insecure with the attachment style, had higher analgesic consumption. Again, so it's a psychological factor, something about that. And it's interesting that it's this concept of attachment, the ability to form emotional bonds, has this explanation for the discomfort that occurs during the labor process. And with that, you already had a chance to see, a lot of people when they chop onions, the trick is not to form an emotional bond. And this is my favorite toy when I was growing up. I loved the Magic 8 Ball. For the young people, you don't know the Magic 8 Ball. The Magic 8 Ball was going to determine your whole future. You'd ask it, are you going to get married? Are you going to go to college? And, it's the thing that I used before I was going to propose. Should I propose to my wife? And the Magic 8 Ball said yes, signs point to yes, and hence the reason I got engaged. And here I am now, 23 years later after marriage. But let's take a look at 50 nulliparous patients. And I think, I feel guilty even bringing this study forward because the author of the study's here. And Brendan, I think, hopefully, I'm trying to think, Brendan, are you on the panel? No, I don't know. But it's an interesting concept. And they looked at various psychological variables. And again, taking a look at this concept of attachment and anxiety. But here you can see anxiety, fear, all these things go into that. And the greatest thing that seems to be predictive of analgesic consumption for this was anxiety. So what we're seeing is that everybody does have the same physiologic process. Everybody goes through the same process. However, the experience reported by them is very different. And here's taking a look at a patient's perspective. And the key things when you ask patients, they're concerned about the uncertainty. They want to be involved in decisions, and they want to be perceive a level of control. That's why I love this. You can understand why people used to bite twigs, in the olden days, because I just wanted to get a hold of something. But then it all went from panic stations to me lying down, watching the telly after the epidural had been insulted. It was great, and went from mayhem to a totally chilled out and relaxed. So that's what we're seeing here, that they do want to be involved in this. Here's a systematic review of women's experience and expectations. And I think the key is that taking a look at this, and it is helpful to us, especially those of us who go to the childbirth class, women tend to underestimate the pain they'll experience, so those are those that are anxious, but they tend to estimate, they have unrealistic expectations about pain, meaning that they're not prepared for labor, and they do want to participate in the decision making. And as Katie nicely pointed out, one of the best things you can do that's non-medication is having continuous presence of a support person. And I think this just really is a reminder to us that what we have to really do is, if we're trying to help our parents and understand, we have to set realistic expectations. They come in with very unrealistic expectations, and we need to make sure that their expectations are correct. And this is just, I thought, just as we're talking about the discomfort, it is not a concept that sets them up for chronic pain afterwards. Taking a look at 1,200 women, and they're going to be following them up until after delivery, and you can see 1 year after delivery, those who delivered did not have the same discomfort. So unlike breast surgery, unlike thoracotomy, where they do develop this chronic pain syndrome, you don't see that in obstetrics. But they did talk about the support person, and I think the most thing that I've learned is, remember, support people are never helpful, at least in my institution. Support people are always, you know, when you take out the epidural and they go, whoa, that's a big needle, and you're like, you know, going back to Dr. Siegel, who talked about nocebo effect, I don't know what that is, where the person's saying, you know, damn, that's a big needle. But here's 84 couples randomized to the presence of a partner, and you realize if you have a partner present, that they actually have greater anxiety score. They actually record more pain with the epidural insertion. So again, it's that anti-nocebo effect, that they hurt more if the partner's present, and the greater anxiety if the partner is present. So here's an example that comes from, actually, it comes from an artwork at the Museum of the San Francisco Museum of Art. And you can see here, this was a tribe in which the women would go into the birthing hut. And you can see here, she's here in the birthing hut, and the father would go up into the rafters of the birthing hut. And you can see where the mother, if she were to experience a contraction, she was told to tug on the ropes. And if you're curious where those ropes are connected to, there's absolutely no question where it is. So both the mom and the dad had the chance to experience the wonders of childbirth. There's no surprise, but if you're curious, yes, this tribe is extinct, and it's probably because you'd only have one kid after this. So what are the fathers' experience of the childbirth process? So here's 10 fathers were interviewed 4 and 15 weeks after, and I think it's interesting because what the key is, they feel very out of control. And if I would have to say, I agree, because that's how I felt when I was having my kids, when my wife was having our kids. You know, and the thing that was interesting is they actually, in this study of 10 fathers, all really liked it when they did an induction or when they started, because they felt finally something was going. And again, they felt a little more in control with that. I just want to throw this in. When we talk about labor, we do have to realize that labor does have an effect on the airway. Here's taking a look at a parturient before and after labor, and you can see it went from a class 1 to a class 4. But take a look here. Here's the airways examined on 61 parturients. And if you look at the airway before labor and after labor, here's an airway that I wouldn't be so worried, and here's an airway where I would definitely be worried. The reason this study is so good, not only did they examine the airways, they also did ultrasound, taking a look at the volume within the airway. And I think the key is that you can see 1/3 had a worsening of the airway and 1/3 had a decrease in volume, suggesting that something about the labor process causes that. And it's, again, probably genomics. Not everybody has it, but 1/3 has it, and it does not correlate with the length of labor and does not correlate with fluids. So what did we have a chance to do? We had a chance to think a little bit about labor and take a look at it. We understand the physiology. Every single parturient undergoes the same physiologic process. However, there is some influence of genetics that we saw that if you have a substitution on the beta-adrenergic receptor, that can affect the duration of labor, and that's generally seen in certain patient populations. We do know that abnormal labor is not good. The longer the labor, the worse the outcome for mom, the worse the outcome for the baby. And what we have seen is, while there are physical and genetic factors, probably the most important that we're looking at is now the psychological. So if we're trying to figure out ways to address this, we've already come up with medications. Now I think that's what Scott touched on yesterday. That's what Brendan's touching on. We have to take a look at this psychological aspect. Something about attachment, which is a process that occurs very early in a person's life, explains 25% of the variability in the sensation of labor that a woman will experience. Very, very fascinating. It very closely also explains the analgesic consumption. And so we're seeing a little bit of this, and I think that's where you're going to start hearing a little more of the discussions in the upcoming meetings, because we have figured out what's the best way to go medication-wise. Now we have to think of the best way to approach people. And the other thing I've learned is that support individuals are never, never helpful. So I've had a chance to talk to my friends that are sitting in front of me. We were talking about marathons. So here's a picture from this year's Disney Marathon. This was me posing with Sleeping Beauty and Prince Charming. And if anybody's curious, That's Prince Charming and that's me, because I know you thought, right, he looks more like Prince Charming. And with that, I'd like to say thank you.